Welcome back to another episode of Care Transitions Today, a healthcare podcast that focuses on case management and transitions of care. This podcast is presented by the American Case Management Association and is underwritten by the Pfizer Foundation. I'm your host, Deb McElroy, and in this episode, we'll be discussing lessons from COVID on case management, education, and I'm delighted today to welcome Diane DiFiore. Diane is currently serves as the Beaumont Health Director for Care Management, Development, Education, and I'm really looking forward to talking to her. I think this is a great segue from some of our previous podcasts. So in her role, Diane is involved in facilitating system-wide alignment for care management. So she's going to be coming from that perspective. And Diane, I'm going to pass it to you. Tell us a little bit about your background and your role.
Well, thank you so much, Deborah. It's such an honor to be with you today, and delighted to talk with you a little bit about my background and then also some of the things that we at Beaumont Health were challenged with during the COVID surge. So I am a nurse by background, and I like to say that I grew up in the Oakwood system and had a variety of roles within the Oakwood system, spanning from staff nursing in med-surg and the emergency department to leadership roles with both site and system span of control in nurse recruitment, in nursing supervision, in director of emergency departments across our Oakwood Health System. And then in 2014, I like to say we all got married. And so we married 3 health systems into one to create Beaumont Health. And it's been an exciting journey as this new company has emerged. And we've really been able to leverage a lot of wonderful talent and innovation. And especially in a pandemic like COVID, we've come to discover the importance of the talents that we have and how we can best work together within our system and within our community to help support the patients that we serve every day.
That's great. So I am interested as we're talking today to really hear your thoughts on how you leveraged that systemness, as well as things that were unique to your individual partners. So thank you for that. So in your role, you're really focused on obviously the training, the education that folks get as they come through as a new employee, as well as ongoing continuing education. But I believe COVID-19 probably put a whole new spin on what that looks like, because virtually everybody needed education very quickly. So can you talk to me about how you did that, the just-in-time training, especially when things are, progressing so rapidly, new information is coming out, et cetera?
Yes. Well, our department, Care Management, partnered very closely with the Division of Nursing. Many of the members of our team are nurses. We also certainly have social workers, as well as utilization management coordinators and analysts who are, some of whom are also nurses. And so instead of reinventing our wheel within care management, we collaborated and partnered with nursing to establish what might be the best way to tap into a vast resource of nurses that are not clinically based, but have clinical and professional expertise. And so what we did in that rollout fashion was we all, as nurses, completed an assessment of our background and how clinically relevant and recent our experiences were. And so the measure of that was if one of our nurses had between 1 and 5 years of recent clinical experience, these were individuals that we were able to then bring into that on-site inpatient setting to work with those bedside nurses to help support the team during this critical time. And so that's what happened. And additionally, those individuals, nurses who had greater than 5 years of being out of the clinical setting, what we did with those individuals was we utilized their talents in different ways. So, for example, I fell into that greater than 5-year category. And so one of the things that I helped support was a call center that we publicized to our entire patient population. And it was a way for us to connect with patients and families who were at home and were worried about what they should do if they suspected a symptom was affiliated with COVID. And I have to say, the experience that I had with the call center over about a 6-week period of time was incredibly, I think, valuable for our community. It was a way for patients and families to connect with a clinical expert who could help talk them through and walk them through some of what they experienced and possibly either guide them toward getting additional care or help them manage their care at home. Some of the calls were incredibly heart-wrenching and also inspirational. I found that on average, we would spend about 15 minutes per caller and really provided a lot of not only clinical support, but emotional support. I think what it also did was it helped protect the resources that were available to our patients through Beaumont Health. And by that, I mean, was this person someone that qualified for maybe getting a nasopharyngeal COVID test? Was this person someone that definitely needed to seek medical care in the emergency department? Was this someone that should connect with their attending physician to get more medical attention in a different setting? And so not only did it provide for a wide variety of clinical conversations that we had with our patients, but also the emotional support and the just really reducing that fear and anxiety that was so palpable in our community. And I'm sure we were not alone in that. This was very palpable across the United States. And so I think that having the ability for nurses to be utilized in settings that were helpful, no matter what level of care we were providing, were really innovative ways to bring clinical staff to the front lines to help support patients directly or indirectly.
And those folks that had more recent clinical experience and were being deployed on the units, were they being used as staff? Were they being used as educators for infection control procedures, that kind of thing?
Actually, all of those that you've mentioned, Deborah, there were some staff who had, very recent experience, and they were redeployed back into the unit that they were had transferred out of in the ICU, for example, step down or med surge. So they were bedside nurses that were utilized again in their former role. Some of the staff were considered like support nursing staff. So the bedside nurse on the unit would go into that patient's room, and if they needed additional supplies, that care coordinator would be assisting in getting those supplies into that room so that the nurse in the room did not have to don off or on again. And that really helped preserve our PPE. It helped preserve an efficiency of workload so that as nurses went into that room from an infection control standpoint, they really were able to adhere in the best ideal way by keeping their equipment on and protecting those patients, but also having that extra pair of hands that could lend themselves to supporting the nurse and the patient. And they were also used in ways of contacting family so that there were still connections with patients. So there were a variety of ways, depending on that level of recent clinical experience, that our staff was used to help support.
That's great. So you talked a little bit at the beginning. So I think as I'm listening to you and as a nurse myself, that makes sense from a nursing perspective. But obviously, case management, as you mentioned earlier, you have folks that are social workers and maybe in other roles with, utilization management. So I'm thinking about being able to maximize folks at the top of their license and utilize. So can you talk a little bit about how you used some of the other folks as well?
Absolutely. Certainly all of our team members are critical to efficient and effective discharge planning. At the same time, we were so challenged across the country with making sure that we had a proper amount of PPE. What we really tried to do was preserve those resources the best way we could. And by that, I mean that one of our initiatives was, obviously visitation was restricted. We also wanted to minimize exposure of our staff and protect them and keep them safe. So our utilization management team actually was deployed back to their home. And so they worked from home remotely. Now, that presented some interesting challenges because of the setup of IT needs, et cetera, at their homes. And I have to say that our IT department did an absolutely incredible job of working under such tight timelines to get these staff members set up remotely. And they did it in record time so that there really was a seamless transition of the utilization management reviewers going from on-site to a remote function at home. We also obviously restricted visitation up on the unit, so our staff was really maintained within the department for those that weren't working remotely. And what these staff members did, both care coordinators and social workers, were that they still connected with patients and families, but they did it through phone calls. They contacted patients directly in their room through their room phone. They contacted family members based on emergency contact lists and had conversations with them that way. So we really worked in ways that were kind of non-traditional, because obviously the most traditional approach we've always had was making that face-to-face connection with patients, face-to-face connections with family and the interdisciplinary team. And that was put on hold. And yet we couldn't stop the work that we were doing, and especially in a time where patients really felt such an incredible sense of isolation, because obviously family could not visit them, and yet we still were connecting with them. And I think that helped somewhat. It wasn't the ideal. It wasn't the normal way, the typical way that we like to interact with patients and families, but we were still making those connections. And so that really helped during this time of this incredible crisis and surge to still work within the frameworks of maintaining that patient and family centeredness, but doing it in a different way.
I'm curious because as you're talking, it really, that initial surge over those earlier months was so critical. So where are you at now? I mean, we certainly know and understand that across the country we still have hotspots. What does that look like for you today?
Oh, well, I'll tell you. So in March and April, that was our most critical surge. And so just to put it in a structure, Beaumont Health is comprised of 8 hospitals under one umbrella. Okay. And we are the largest health system in the state of Michigan, and we got hit the hardest. And our maximum level of positive COVID patients in our hospitals reached 1,200 across our 8 campuses. Putting it in perspective in today, current state, we are ranging between 120 and 200 COVID cases across all 8 of our hospitals. So you see the dramatic decrease.
Absolutely.
We are starting to hear more and more about, this little uptick in surges. We're watching that very closely. Every day we look at those statistics and our data. And interestingly enough, I think we've learned so much about a pandemic. We've learned so much about our capabilities as a health system. We've learned so much about how our state of Michigan has helped support all of the health systems within our state in maximizing our efficiencies and caring for patients across our communities. And we are so much better prepared, locally, at the state level, et cetera. And within Beaumont Health, we are so well prepared on the PPE supplies, syringes. If the vaccine comes into play soon, we are ready. And so we've learned from our past as far as emergency preparedness, and we are certainly much more prepared from that equipment sense, and even from clinical expertise and how it is that we cascade information out. It's just been a tremendous learning experience for all of us.
So, as a follow-up to that, so you had folks during the most acute phase of that initial surge sort of redeployed. It sounds like with different, what does that look like today as you're, certainly it's still very present and you're having to think about education and training and preparation for what comes next. Just organizationally, what does that look like, and operationally?
Yes. And based on what we learned from that initial surge and how it was that we prepared, I'll use the example of nurses, how we prepared nurses who were not in a clinical setting to resume back into a clinical setting. And we did learn from that assessment that we all completed was helpful, but we wanted to go a step further to say, if this surge occurs again in a way that is going to necessitate much more clinical support at the bedside, let's look at things a little bit differently. And so again, partnering with nursing, they've done a fantastic job of actually providing online and hands-on types of refresh for our clinical staff. And that has been a tremendous help. And so from something as simple as all of us getting our certification or recertification in basic life support, for example, doing the online modules so that we are refreshed to the level of our comfort in where it is we feel we would like to be able to contribute and help at the bedside. And so there are different tiered approaches that nursing has designed that affords a nurse the ability to say, I really want to help, and I can help up to this level. I really want to help, and I can help all the way to, getting in that clinical setting and helping out. So it's been very insightful from looking back as we've debriefed and said, what could we do better? And then designing something that helps support our teams so that staff feels very comfortable raising their hand and saying, yes, I can do that. And if with adequate refresh, I'm certainly feeling more comfortable to be able to do that.
Good. Good. So I'm thinking about our constituent group from the American Case Management Association. There's some things that came up um, during the course of COVID. One was legislative changes and some waivers, right? So that things that were not historically covered, or some of the um, operational steps that needed to be done before someone was transferred to another setting of care, looked a little bit different. So can you talk a bit about deploying that education even to the physician communities, because they needed to be kept apprised of the quick changes that would make a difference in how they operated as well?
Most definitely. We had deployed our command center both corporately and at all of our local sites. So we have a very good structure of how communication travels up and down. And so from the standpoint of legislative changes, we have within the Beaumont Health system several, well, certainly a department. It's a government affairs department within the Beaumont Health system. And they had been giving us in real time legislative changes that were occurring, waivers, et cetera. The beauty behind the government affairs department was, and it was certainly eye-opening to me, because honestly, I've never really had that direct of a contact with how the work that I do as a nurse, for example, or the work that I do within care management has such a tie-in to legislation, only because it's there and we follow rules and regulations. But when we have this real-time need and we're saying we've got to escalate this up to the state, we had the mechanism to do that. And it worked very well. I would say that our voice at Beaumont Health was heard at the state level. And so some of the things that we did was in understanding what legislative changes were occurring within care management. For example, every time we got an update, whether it was CMS or through LARA, our licensing and regulations affair division, or the Michigan Department of Health and Human Services, or the CDC, whether it was state, national, even local, we in care management were always issuing clinical alerts. And those alerts were then being deployed to our site leaders within care management, who were then deploying it out to their employees directly. Now, from the physician perspective, we also have a corporate infectious disease physician who has system-wide ownership of infection prevention. And Dr. Gilpin is our representative, and he was also very effective in how this communication occurred across the span of all physicians. We leveraged a variety of methods of communicating this out. Certainly email was one way. We used our Beaumont website. We also have a care management website, all intranet based. There was also internet based communications that came out through our physicians, for example, letting the public know what the guidelines were, what Beaumont was adhering to, how you could feel safe, especially in light of when visitation at some point was lifted in a very conservative fashion, just to let the general public know about that. But we used a variety of ways, even funny that we're on a podcast, but we used even podcasts, both internally and externally, to communicate to the general public, to our Beaumont colleagues, our Beaumont physicians. And that seemed to be a very, very effective way. And it's interesting because throughout the course of our journey, with the surge impacting us from mid-March all the way into, early May, we saw a lot of different obstacles that occurred naturally because each of our constituents, our community partners, were trying to work within the framework of what they had. And by that, I mean our skilled nursing facilities, for example, were very challenged with staffing, with PPE, and with how it was they were going to accommodate accepting patients from hospitals. And it really created a serious dilemma and one of public safety. And we recognized that. And it was such an interesting dilemma because, we were caring for patients who were then ready to move on to that next site of care. However, that next site of care was experiencing challenges. And how could they open the door to us when they were fearful of impacting their vulnerable patient population? And so it was really a great effort, and I think a compliment to our post-acute care partners and Beaumont Health when we worked together within care management and our post-acute providers to say, could we speak on the phone daily? So we had a daily call, a standing call Monday through Friday at 11 a.m. with our skilled nursing facility partners. And there were about 95 skilled nursing facilities, or SNFs, as we call them, who collectively came on a call with Beaumont Health each day. And we had a spreadsheet of questions that we asked. How many beds did they have available? Were they accepting COVID patients? Did they have negative pressure rooms, et cetera, et cetera? Did they experience PPE issues, staffing issues? And what was so instrumental in those calls were certainly that list of information, that Excel spreadsheet, we then pushed out to our site care management leaders every day so they knew exactly in the community what number of beds we had available to us and how those beds could be best used. But in addition to that, the barriers that our SNFs were experiencing, we then escalated up to our government affairs group within Beaumont Health. They escalated up to the Michigan Hospital Association, and that helped facilitate SNF relief. So it was a really great collaboration. And I have to say, at first, when that first week that we got on those calls with our SNF community partners, in total, there were about 28 beds to be shared by Southeast Michigan, which was, my goodness, just a drop in the bucket. But as we started to work more collaboratively, and then as the MHA and the Michigan Department of Health and Human Services really helped support our community-based SNFs, they started to design what were called regional hubs. And those hubs were where the COVID positive patients could go. And that was kind of that bridge where they isolated those patients and safely protected them from their own population of high-risk vulnerable patients.
So were those hubs a skilled nursing facility?
They were.
They were.
They were.
So they were a designated SNF for COVID.
That's exactly right. And that really helped decompress our hospitals across Southeast Michigan and even, beyond in our mid and northern sections of the state. In addition to that, the state of Michigan opened up some additional centers for us that were, they were regional hospitals, and they were there to help also decompress patients to another alternative site where care could be managed. The thing about the regional field hospitals was the criteria was rather stringent, and the patients that we had that were ready for discharge, didn't necessarily qualify. Our patients were really at a point where they were stable enough maybe to go home, and to send them to this regional field hospital just seemed a bit redundant. And so it didn't really benefit us. But certainly I think the concept was good, and the intentions were certainly ones that we appreciated, but just couldn't really utilize the resources because of the stringent nature around the accepting criteria.
So I'm interested, you've mentioned this several times, a couple of things that I've heard as themes over these podcasts. One, that IT's been an essential partner, but the community partners were critical. And so I just to loop back a little bit on the communication. So you've got folks internally with your care management team, in a phone center, and some up on the units, and you've got your community partners needing to develop the criteria, I believe you're talking about, as well as enforce that. So it sounds like your public affairs folks were really driving some of the communication plan. You talked about being on with the community partners once a day. Any other success strategies in terms of communication to make sure, because I'm thinking like the 2 midnight rule, some of the other waivers is a sort of great, significant adaptation that came forward as part of COVID. But how do you continue to communicate that through people who are in places they weren't in before?
Yes, very good point. And another kind of segment of communication that we did, and we did it rather quickly early on in mid-March, we started to see payer restrictions. The traditional payer acceptance or denials didn't fit with the COVID framework that we were dealing with. So we sent a letter to all of our local payers requesting some softening of the rules around what it is that we could would be acceptable for admissions, and what could be something that we could forego or pause for a period of time, because certainly we were in the middle of an emergency. We were in a situation where we had to rethink some of the rules and regulations that we've all abided to, but at this point in time didn't really fit. And that was also a very interesting and beneficial collaboration. I would say that we saw most of our payers say, "We understand. We truly get where hospitals across our state are coming from." And so our payers, for the most part, really helped kind of readjust through waivers, or just putting certain things on pause where we didn't have to do, for example, a 3-day inpatient stay in order to qualify to go to a skilled nursing facility, or some of the different ways that utilization management review was occurring wasn't necessary at that point in time. So we were very fortunate that most of our payers really got on board with all the healthcare systems within our state, and worked together really for the good of our patients.
That's great. So, again, I think top of mind has probably been to look at what you've experienced. And you talked a little bit earlier about debriefing and trying to do lessons learned. So current state today, again, one of the things that we appreciate you being here is as an expert with the education and the training and the thoughtfulness. So I guess what is happening today that you're really focused on, in terms of making sure people are up to speed, certainly what the payers are doing today, maybe as opposed to what they were doing 3 months ago. And then obviously you have to try to anticipate what's coming down the line.
Yes, that is certainly a reality. I agree with you, Deborah. And we have learned a lot about how we can prepare. And it's interesting because, I think that we've always felt a sense of preparedness for emergencies. And part of my background has been in emergency nursing. And I have, through our teams, our emergency department teams, we've created emergency preparedness plans. And in all honesty, I could have never made this one up. It was just so far reaching and so multifaceted and so complex, and just really created so many different nuances of preparation. And within the care management arena, we have certainly, from an educational perspective, really prided ourselves in promoting really solid onboarding. And that was established in January of 2018. So all of our newly onboarded staff, and even our staff that are incumbents but want to get kind of a refresh on rules and regulations, or learning around the best mechanisms for communicating with patients and what different communication strategies there are. We've embedded all that into 2 orientation classes, each that are 4 hours in length. And that has been a very effective way to create that baseline knowledge that all of our staff members are onboarded with. But in addition to that, we utilize the Compass modules, and those have been a very strong foundation for us. And I have to say that at the end of 2019, our Education Steering Committee had really high hopes and chosen 3 full courses within Compass for all of us to do our online training for 2020. And then, this unusual thing called COVID entered our world, and that changed the dynamics of the reality of how it is that we could expect our staff to really focus on some of this training. So what we did was we reevaluated the course curriculum, and we modified it, albeit still having staff complete 2 of the courses for the year. And we are certainly excited for 2021 to embrace more of those Compass modules, so that our staff can continuously be prepared and understand the whole methodology and rules and regs around care management and utilization review. We also have really driven home the importance of certification, and we promote the American Case Management Association certification, so that our staff then gets that higher level of insight and professionalism. And so those are a variety of ways that we've really tried to maintain competency and education, especially in light of this pandemic, that we have to be on top of our toes even more so now, so that our staff is really well prepared. And as I mentioned, we have a really robust care management website, and that affords our patients that source of truth. Everything that is posted on that website is current and validated, versus in the past where, our team members would print off a checklist or a document only for it to be as current as the date it was printed. And we shared those things with others 6 years later, and who knows how fresh that information was. So our website is a great way for our staff to tap into utilization management, regulations, policies, community resources, et cetera, education. And so they then can better understand and equip themselves with the tools they need to function, daily.
Yeah, and appreciate highlighting the Compass educational tool from ACMA, because it does, I think, fit some of the needs of a pandemic environment where that online learning is critical. As you said, competency is critical in these times, but it needs to be on demand kind of education. Do you see anything changing sort of moving forward? I don't know if you still have some of the staff working remotely, if they continue to work remotely, as you're thinking about annual reviews and assuring competency, new training. We still are not totally clear on what's going to happen with the CMS waivers on some of these things. So going forward, are you anticipating changes so that you can do some education real time, and what will that look like?
So, when we lifted the visitation in our hospitals and allowed for one visitor per day, that's when we then relooked at our staffing model and felt through, approvals within our own leadership that we could bring back the staff that had been deployed home. And so now our staff is fully back at our campuses. And they are certainly going up onto the units now, being obviously very careful and using PPE appropriately. In a moving forward fashion, we are doing the onboard orientation on site and doing the social distancing and the masks. We have found that seems to be a rather effective way versus some sort of Zoom or remote setting. However, other education is still being done remotely. Meetings are still being conducted remotely. And so because of that caution and that concern about this additional surge, we are still taking those extra precautions of maintaining a safe environment for how we provide education, but doing so in a way that we hope can be somewhat effective. But, we, I think, would really welcome the ability to have, what we looked forward to in the past, where we might have an annual conference or, group presentations. They all have a different look and feel to them right now, because we really want to adhere to what is being provided to us by the CDC.
Yeah, and I'm sure folks are excited to be back on site when they're able to do that. Just personally, I'm curious, your lessons learned for yourself. We've navigated, as you said before, unprecedented times. You've got a background with emergency services, and so I'm sure in the past you have prepared for many scenarios. This looked a little different. Anything personally that you're taking away from it that feels like, okay, this is my lesson learned that will make a difference going forward?
It's such a powerful question that you ask. And there were many and have been many things that I've learned and appreciated. Taking for granted the fact that we interacted with people face to face, and that we've lost some of that. And yet I think that when we have gone into this remote approach to meetings, for example, and we introduced a new meeting format through Teams, in sharing our screen where everybody could see our face. I'll never forget the first time we had one of our care management leader meetings where all of us were, showing up on the screen. It was like the Brady Bunch, where we all could see each other in the squares. I can't tell you how excited and happy we all were that we could actually see everybody, not just hear voices, but see everyone. So, lessons learned for me were not taking for granted that freedom of the ability to interact with people in a way that we just never thought about. And now we've got to be so careful and so cautious and so protected. But it has certainly also built relationships for us in a way that we now don't take for granted the ability when we can to see someone in person and have those real-time face-to-face conversations, whether it's with patients and families or colleagues or family members. I think that this pandemic has made us very agile, very flexible, very open to innovation. There was a time where I think working from home was not considered to be the common approach to how we do things. And yet now it is pretty customary across industries. And I also have been a very strong proponent of telemedicine, especially with my background in emergency nursing. And I can see now the benefits of having telepsych in emergency departments, having telemedicine where if you have a mild symptom of something, we don't have to wait several weeks in order to see our doctor. We can connect with them by phone remotely and tackle that problem in a much more timely way. So I think that there are many silver linings in all this. It's been a tough go. It certainly hasn't been for the faint of heart, but I think that we've all walked away learning and appreciating things and just being much more creative and open to new ideas.
I love that you talked about the patients and families, because I think about, I am a former case manager and, certainly in different roles throughout my career. I think what you said is exactly right. We've taken our communication for granted. And now I would suspect as you move forward, there's going to be an emphasis too on how people in the roles that you're educating, how they communicate, because it might not always look face to face, which is, our default and is intuitive. I would suspect that that's going to be something that you'll follow and weave through your curriculum as well.
That's such a good point. You're absolutely right, Deborah. And really integrating these other additional ways of communication that we probably just didn't tap into before. And now, we have that opportunity to say, well, did it work? Was it okay? Was it effective? Were we able to connect with our patients and their families? Then let's be open to that.
Yeah, I love that. Anything else as we wind up our conversation today? Anything that you can think of that you'd really want this group that's listening today to know or understand? Any other comments?
Well, I would say that every discipline within the healthcare system comes to the table with an incredible skill set. And we have tapped into a lot of disciplines that I don't think we would have typically done so at the level that we did, like, for example, IT, infection control, the state as it relates to legislation, the different layers of how it is that we as a community, we as a state, we as a country can all come together to say, how do we make our health system better? With the cards that we were dealt, how can we advance and make that patient and family experience within our healthcare settings, whether that's inpatient, ambulatory, outpatient, whatever, the best it can be with the safest high quality care. So I congratulate all of our colleagues, and I think that everybody has tried to do the best they can do and have really stepped up to the plate. And I just think it's been an amazing journey, and just really appreciate the fact that everybody feels the sense of collaboration and partnership on how it is that we can get the best outcomes with what we have.
Well, thank you for those comments, and I certainly appreciate you taking time in this still very busy, difficult environment to take time and talk with us about your experience. If you've enjoyed listening to this podcast, we'd love to hear from you. Please leave us a written review and a rating so that we know what you think. Also, be sure to subscribe to Care Transitions Today. That way, you'll be the first to be notified when we publish new episodes.